Medurstand Understanding Medicine.
I'm Professor Aziz Rehman, and this is the second of the series of two lectures. In the first one, I discussed the etiology, pathology, and the different clinical manifestation in chronic kidney disease, also called chronic renal failure. And in this one, I would focus on investigations and treatment principles. So if you have landed up here directly, I suggest that you should first watch my earlier video and then come here. So let's get started. So in investigations, there are three types of investigation, three groups of investigation. The first one is called screening, and this we do when we are treating somebody for some other condition and we suspect that there may be kidney involvement, and periodically we do some very basic kidney function tests just to be sure that the kidneys are not affected. And if there is an indication that the kidneys are getting affected, then we go to the furthest next step, and that means routine lab tests, which is a set of investigation which will give you a complete picture about the kidney status. And then some specialized tests, because kidney disease is often the result of many other diseases, so sometimes we have to dig deeper and find out what is the cause of the kidney damage, and we may be able to address that to slow down the progression of the disease. So we might have to do further tests, and this I would discuss very briefly. So in screening tests, I told you the example, whenever we are treating somebody with some condition which could lead to kidney damage. I think two common conditions as internists which we treat is diabetes and hypertension, and many times they coexist. So if you're treating any of these two conditions or any chronic condition where you suspect there could be kidney involvement like an autoimmune disease, then you should do these screening tests periodically. And these are the screening tests. Basically, we test urinary albumin. You know, in urine, normally there should be no albumin, at least not detectable with ordinary dipstick method. So you could do the urine test for small amount of proteins. One is simple spot urine test. That means whatever time patient visits you, you could just collect the sample and see if there is any protein. Having protein in spot urine would clearly indicate an abnormality. But more precise is albumin creatinine ratio, because this would also correct for the kidney if the state of hydration. You know, this would measure the absolute amount of protein in the urine at that time. If urine is concentrated, the value would be more. If urine is diluted, depending upon patient's status of hydration, the value may be less or albumin may be negative. But this one will correct with creatinine. So if patient is dehydrated, both will be concentrated, and if patient is well hydrated, both will be diluted. So the ratio will remain unchanged. Albumin is measured in milligrams and creatinine is measured in grams, so the ratio of 30 or above is abnormal. Then simple urine examination, if somebody just have his routine urine examination and that shows proteins or cast, that would also indicate that you need to do further tests. And I think the next test would be what we call renal function test, and serum creatinine is the best indicator of kidney function test among the blood tests. So serum creatinine, and you know the normal value varies from in different genders and also based on your weight. So you would make the judgment accordingly. So if the screen tests are negative, that means that you do not need to proceed with the further test. But if the screening tests show abnormality, then you need to define the exact status of the kidney, and then you need to go for the further test. And these are called renal function tests, often abbreviated as RFTs, and this includes blood urea nitrogen, creatinine, serum electrolytes should always be included because they can be affected, and arterial blood gases. So I have given details of all these in my earlier lectures. So in this, I think very briefly, creatinine would be expected to be high, blood urea nitrogen would also be expected to be high. In serum electrolytes, you would expect, or you would like to rule out hyperkalemia. In arterial blood gases, you would like to rule out metabolic acidosis. And then urine complete examination. A careful urinary examination is called uh, a non-invasive kidney biopsy. And of course, it is not a biopsy. That means it gives you a wealth of information. So presence of protein is abnormal, and then you could do further differentiation. Which type of protein? Is this albumin or globulin or small chain, heavy chain? So these kind of things can be done. And then cellular debris. If the cells are present, of course, white cells may be present in case of infection. RBCs may be present in the case of menstruation, if the urine is collected during menstruation. By the way, if a woman is menstruating, urine sample should not be collected at that time, so because that would mislead you. And presence of cast would also confirm kidney disease. Then in CBC is a very basic test, and we always do it in almost all diseases. But in kidney disease, what do you expect? What do you want to rule out? Anemia. There are several reasons for patient with kidney disease to have anemia. The most important one is erythropoietin deficiency. So you expect normochromic normocytic anemia. So HB may be low, hematocrit may be low, and indices may be indicative of hypochromic microcytic picture. I have a separate lecture on interpretation of CBC. If you're interested to know more about the RBC indices, you could refer to that lecture. Then calcium and its associated factors, like serum calcium must always be measured, phosphate should be measured, alkaline phosphatase should be measured, vitamin D should be measured, parathyroid hormone should be measured. Calcium is likely to be low. Please rule out hypoalbuminemia because you need to correct calcium level for albumin. Phosphate is likely to be high because phosphate is retained in kidney failure. Alkaline phosphatase would also be elevated because of secondary bone involvement, because of secondary hyperparathyroidism. Vitamin D, the active form may be low. The total vitamin D may be normal, but vitamin D, the active form may be low, and parathormone is usually high due to secondary hyperparathyroidism. Because of low calcemic and hyperphosphatemic state, the parathyroid gets stimulated and there may be secondary hyperparathyroidism. This can be viewed as physiological adjustment by the body, but it can actually be responsible for progressive bone loss. So most physicians and most nephrologists, they want to address this component also. So you need to know if there is secondary hyperparathyroidism also. Then ultrasound is very good simple test. You would like to know the kidney size. Normally kidneys are 10 centimeter or bigger, and if the size is 9 or less, that is small. Of course, we're talking about the adults, and especially if the echogenicity is changed, if the kidneys have become more echogenic and the outline is now less well defined and is not easily differentiated from the surrounding tissue, that would indicate renal parenchymal disease. So other tests, this I will be very brief, depending upon the suspected etiology, and this usually refers to the cases where you suspect autoimmune diseases, anti-nuclear antibodies, serum complement level, anti-GBM, this is glomerular basement membrane antibodies, if present, Goodpasture syndrome, and C-NCA, P-NCA. I think this may also be present in Wegener's granulomatosis and other diseases. So these would be done only when appropriate. Kidney biopsy, of course, is the ultimate. We don't do kidney biopsy when the cause is obvious. Like for example, in hypertension and in diabetes, we don't need to do kidney biopsy. But if there is unexplained kidney dysfunction, then kidney biopsy is usually done, because only kidney biopsy will give you the histological details, and it would also be able to pick up a treatable condition. So kidney biopsy would be done only by a trained nephrologist or interventional radiologist. So I think based on these, the condition you would do these creatinine BUN are often repeated, because once you are treating the patient and then you like to know the progression of the disease, or if you have achieved regression or whatever, so you need to know the course of the disease. So these are the investigation. Now we're going to talk about the treatment. First, let's talk about the treatment objectives. What are the treatment objectives and how do we achieve those objectives? So first, I think the objective as a student, you would think the reversal of the disease. That, of course, if possible, would be an ideal. But very unfortunately, it is only rarely possible. Completely treating the disease and reversing the kidney disease process is usually not possible, but it is not impossible either. I mean, there are some situations depending upon the disease, so I think that should be your first aim. But more practical and more doable plan is to try to slow down or halt the disease progression. And this is often doable, at least partly. So what we do is remove the offending agent. If somebody is taking some drugs which may be responsible for kidney damage, and the best example here is non-steroidal anti-inflammatory drug. So if somebody is taking that drug, I think the first thing you need to do is to stop this medication. In my experience, nothing is more rewarding than correcting patient's problem by discontinuing a medication. So this is very, very rewarding. And then control underlying disease. Whatever the disease is, underlying hypertension, diabetes, autoimmune disease, we try to control that. And then if you take the example of diabetes, you of course try to get his HbA1c to the best level, less than 7 or 6.5. But you must know that once patient has got kidney involvement, that person becomes more prone or more vulnerable to develop hypoglycemias also. So I think HbA1c of less than 7 would be ideal. Of course, if you can get it to 6.5 without hypoglycemias, that is best. And all anti-diabetic agents are not equally good here. Particularly, I like to mention SGLT2 inhibitors, which are nephroprotective, renoprotective, so they should be used. GLP-1 receptor agonists, they also have shown some benefits in the kidney disease, or at least they do not have any adverse interaction, and of course insulin. Some drugs are typically discontinued or at least the dosage is reduced. Like for example, metformin, if the GFR is less than 45, then we restrict metformin to 1 gram, and if it is less than 30, we then stop it and we do not start on the new patient. Like insulin should be very, very safe in kidney disease, but you need to know that you would probably require lesser dose of insulin as compared to another person with the same degree of glycemia because of hypoglycemia risk. Initially, when we use SGLT2 inhibitors, and initially there would be some drop in GFR. Now, so you will obviously monitor them. If the patient has got hypertension, you use angiotensin converting enzyme inhibitors or angiotensin receptor blockers. And the aim should be to keep blood pressure below 130/80. This is what most societies say, although JNC 8 says 140/90 is good enough if you can keep it below, but I think 130/80 or less would be best. In both these conditions, you need to keep an eye on GFR. You must monitor GFR because initially there is likely to be a drop in GFR, and exact mechanism is not easy to understand, but that initial decline in GFR, if it is less than 25%, then you must continue these drugs. If the decline is more than 25%, then you must stop these drugs and change the alternate therapy. Even if there is initial reduction in GFR, these drugs still offer renal protection. Then treatment of acidosis. If somebody has got acidosis, now the trials have shown that treating acidosis with oral sodium tablets can slow down further progression of the disease. You have to watch sodium because these patients are very likely to retain water, but I think small dose of oral alkali may be helpful to slow down disease progression. So this is more doable. We focus on these with the hope that we can slow down further progression of the disease. And then the symptomatic treatment. These patients, since there is extremely wide spectrum of the disease, from head to toe, any organ can be affected, and you can have any symptom listed in the book of medicine. So you would treat accordingly, like antiemetic, proton pump inhibitors, H2 blockers, paracetamol, tramadol. Since you're not allowed to use non-steroidal anti-inflammatory drugs, so alternate drug, paracetamol and tramadol are safer, or just any drug depending upon the condition. As I told you, there could be, like furosemide may be needed, many other drugs may be needed. Then offloading kidney. Now this is a very, very important concept. Up till this time, we were trying to preserve kidney function or improve kidney function. But one strategy is to offload kidney. We have tried our best to improve kidney function, but at the same time, if we can reduce the burden on the kidney, I think that will also help the patient and will improve kidney function. Now restrict water and salt substitutes and salt itself. Water, because these patients are likely to have water retention, they may have edema, so accordingly, according to the urine output, you will allow certain amount of water, and of course you have to provide at least some amount, which is obligatory. You would restrict salt, the sodium chloride, because unless you restrict salt, it is not possible to restrict water. And then salt substitutes. Many patients who are advised not to take sodium, they take salt substitutes, and often they contain potassium. So potassium may be more harmful than sodium. So I think just go through patient's prescription. If patient is taking some salt substitute, that should also be discontinued, and if it is particularly potassium. Restrict proteins to 1 gram per kg body weight. You know, proteins are essential, but proteins are source of creatinine, urea, uric acid also. So protein should be restricted. I think 1 gram per kg body weight of high biological value protein should be recommended. Previously, we used to think that the proteins coming from the animal source are better because they have their amino acid composition is more like humans. But it has been observed that plant-based proteins may be as good. In fact, they are tolerated better. So both protein, a mix of both animal and plant proteins can be given, but the total amount should be around 1 gram per kg body weight. If you do not give protein at all, there may be some improvement in urea creatinine, but patient will lose muscle. Patient will lose his lean body mass. That is not something that we want to do. Restrict potassium and phosphate and magnesium, and you need to know the diets. Basically, potassium is widely distributed in plant-based diets, and phosphate is also distributed in plant-based diet and also in the animal-based diet, and magnesium is also present in many diets. So you need to restrict all those diets which are rich in this. So I think it would be best if you take the help of a properly trained nutrition specialist. Supplement calcium. Most these patients are hypocalcemic, and you need to give calcium, not just any type of calcium, and calcium carbonate is best. I'll tell you later why calcium carbonate, but you need to give them some calcium, and you also give them bicarbonate. So calcium carbonate is very good. So bicarbonate to correct acidosis and reduce renally excreted drugs. There are many drugs, and if you're not sure, I don't expect everybody to know about every drug, if it is renally excreted or not. So if you're dealing with such a patient, just see the internet, and it is now very easy to get the relevant information. See how much drug is excreted through kidneys. So if it is less than 25%, it may be okay, but if it is more than 25% excreted through the kidneys, then you need to at least reduce the dosage, if not discontinue the drug. Another objective is correction of anemia. So this is actually further step, because many patients with renal disease, they are anemic, and the reason is that they have multiple reasons actually. They may be anorexic, they may not be taking enough food, and so there may be deficiency of iron, there may be deficiency of folic acid, deficiency of vitamin B12. So all these must be given. But remember, it is also possible that these patients already have enough of it, but because of absence of erythropoietin, these patients have deficiency of erythropoietin, and because of deficiency of erythropoietin, they are not consuming their nutrients, so they are accumulating. So but when you give erythropoietin, I think you must make sure that they are also getting enough supply of these drugs, because once erythropoiesis starts, patient is going to need all these ingredients for RBC production and white cell production. So you don't want that the treatment to fail because patient was absent, that the patient was deficient in these. So erythropoietin is available, and it is typically given 4,000 international units subcutaneously. Subcutaneous route is the best one. If you compare it with the intravenous or intramuscular, subcutaneous route is the best one, because that stays in the system for longer and has got better effect. And darbepoetin is a derivative that can also be given. So not every patient, if somebody's HB is already above 10, that patient might not be given erythropoietin, and you have to keep it between 10 and 11.5 to maintain their good quality of life. Going beyond 11.5 is not desirable. So that was the correction of anemia. Now let's talk about the prevention of bone disease. Patient with chronic renal failure, they are likely to develop several types of bone diseases, and because of, for example, factors are like chronic hypocalcemia, chronic secondary hyperparathyroidism, chronic protein malnutrition, renal acidosis. So all these contribute to, and vitamin D deficiency contribute to kidney bone disease. So calcium carbonate is given. Why calcium carbonate? Because calcium carbonate will serve two purposes. If given with meal, it will, number one, supply the calcium, and that calcium supplement was needed. Patients are hypocalcemic, but this carbonate will bind phosphate. Calcium carbonate will dissociate into calcium and carbonate in the stomach, and then calcium would have the option of binding with carbonate or phosphate coming from the diet. And of course, we are restricting phosphate in the diet, but still some would be coming. So since calcium has got more affinity with phosphate, so calcium phosphate salt will be made, and that will be excreted through the stool. So by giving calcium carbonate in a relatively large dose, you have replaced calcium as well as you have removed phosphate. But this purpose will be served only if you give this drug with meal. Phosphate binders are also available, and Sevelamer, like that one, can be given if calcium carbonate alone is not good enough to bring down phosphate to the normal level. It is very important because main factor for secondary hyperparathyroidism is elevated phosphate, and so you need to bring it down. And then calcidiol or calcitriol, you know, vitamin D is activated in the kidney. You could give calcitriol, which is the ultimate active form, but calcidiol is also good enough. In the calcidiol, actually, the renal component, the renal conversion is done. The liver conversion will be done by the liver itself in a normal person, the person who has got kidney disease, but the liver is normal. So calcidiol would be technically better because the liver will still have the control of how much active vitamin D is needed. So risk of hypervitaminosis D would be less with calcidiol. Calcitriol, since it is an active form, if you give it, might work faster, but it might lead to hypervitaminosis D. So I think both are acceptable. In my opinion, calcidiol may be safer. Then calcimimetic drugs, there are certain drugs, if given orally, they could actually mimic calcium, and the receptors on the parathyroid gland and other tissues, they would see it as calcium. So then hyperparathyroidism will be tamed down. So this is one strategy which we have to use to control secondary hyperparathyroidism. So that was the bone disease. I think we are now coming to the end of my presentation, the renal replacement therapy. What is that? I think anything, if somebody, whatever the underlying disease, despite your attempt to halt the disease and despite your attempt of offloading kidneys, some unfortunate patient will continue to progress to the next level. So if somebody has developed CKD5, that patient might need renal replacement therapy because the kidney functions are so poor that patient cannot have a normal productive life, or actually life may not be possible. So renal replacement therapy can be done in the form of hemodialysis, and it could also be done in the form of continuous ambulatory peritoneal dialysis. Both have their merits and demerits, and I intend to cover this in a separate lecture. In fact, the next lecture, I would request you to join me to attend this one, and I'm going to cover this too. Of course, this is the domain of a nephrologist, but as internists, you need to know which one is better, which patient should be offered which one. As an internist, I think you need to know. So I'll share my experience with these two in the next lecture. Ultimately, most patients, if they do not die of some other complication, atherosclerotic cardiovascular disease or some severe infection, septicemia, they might need renal replacement therapy. In fact, prevention of this renal replacement therapy is given only to those patients who cannot have renal transplant. So the ultimate actual treatment of chronic renal failure is renal transplant. But if that is not possible, or while you are preparing the patient for renal transplant, you can offer renal replacement therapy. And you could have a renal transplant from a living donor. That means somebody in the family volunteers to give his kidney, and luckily, since we have two kidneys and one is usually good enough to carry out the function of body, so a otherwise healthy donor who matches antigenically with the recipient will give one kidney, and that may be transplanted. This is one option. In some countries, it is not considered ethical, because though there is minimal risk to the donor, but there is actually some risk to the donor also. So they prefer a deceased donor, cadaveric. So this science is developing in certain countries. Because of religious reason, this is not acceptable. So I think both you need to know, one of the two may be appropriate. Then very recently there have been an experiment. I read an article in the New England Journal of Medicine recently. Somebody was given a xenograft, and if that becomes successful, that would bring another revolution. So a kidney taken from an animal would be one possibility. Still, there would be ethical issues, but I think since every animal also has got two kidneys, maybe, and animals are also sacrificed for eating purposes. So maybe I think this could provide a good source of transplantation. So this brings me to the end of this presentation. Let me give you the summary of part 2. A screening investigation should be done whenever you have a patient who could develop chronic kidney disease, like patient with diabetes and hypertension. Typically once a year, they should have their urine protein done. Renal function tests, and they are done when this is positive, and they are often repeated periodically, maybe every 3 months, maybe every 6 months, depending upon the tempo of the disease when you're treating, because you have to know if patient is improving or otherwise. Other investigation and kidney biopsy as needed. So treatment aims to basically slow down the disease progression and also to offload kidneys. But in some cases, ultimately kidney transplant may be needed. So this has been Professor Aziz Rehman. I have covered chronic kidney disease in 2 lectures, and the third one coming up, which is relevant, would be on renal replacement therapy. I do hope that you join me in the next lecture also. Thank you.